These are my disclosures. So to illustrate the incidence of what I'm going to talk about today, this obviously is the pie graph, which depicts the alterations which we're now familiar seeing in adenocarcinoma of the lung. So translocations involving ALK still comprise about 3 to 7% of this. So the incidence certainly is not as great compared to EGFR and KRAS. However, as we have more therapeutic options for these patients, I think their prevalence is certainly notable in our clinics as we see them coming back for second and now third line treatment. Also today, I will focus briefly on RET as well as ROS-1. As you can see, these also are about 1 to 2% incidence of adenocarcinoma. And Dr. Paik, who will be following me, will discuss some of the others. So to start with ALK, so the most common partner in the ALK fusion is EML4. We now know that there are many variants of translocations possible. And the FDA-approved assay to detect an ALK translocation initially was the break-apart FISH assay. The rationale being if you have a probe on the 3' and 5' end of ALK, you can see a split signal. Now we also have the availability of immunohistochemistry, which is another FDA-approved assay. And some of the next-generation sequencing platforms do pick up ALK translocations as well. However, that's not an FDA-approved methodology. So initially, back in 2009, Alice Shaw had reviewed at the time the clinical and pathologic features of EML4 ALK translocations. And in a series of 141 patients, about 13% in that series had ALK translocations, 22% had EGFR, and the majority were wild type for both of those. It was clear that many of those tumors were adenocarcinomas. They were resistant to EGFR tyrosine kinase inhibitors, which at the time was the first agent that may have been given to some of them, given their non-smoking history. And we know that they tend to be a younger patient group, and certainly we've seen all ages of patients come into our clinics, but with this particular variant of lung cancer, I've seen patients in their 20s and 30s and 40s, which is definitely a unique feature compared to our general population. So there are multiple agents which have been studied and are being studied. Crizotinib, which I'll review, is the first agent to receive FDA approval, followed by Ceritinib. And then I'll touch upon data from these others as well, notably the AP26113, which is now known as Brigatinib, and Alectinib. So Crizotinib was initially evaluated in a phase 1 study, and an expansion cohort was enriched for patients who had ALK translocations. The response rate in that population was 57%, with about a third having stable disease. And this depicts the responses that were seen at that time. And certainly, clinically, this was a patient population that came in very sick. Many had already received chemotherapy and were progressing. And I think within days, it was clear they were having a benefit to this agent. So follow-up studies were done in the second-line and first-line setting. And in the second-line setting, patients were either randomized to Crizotinib or chemotherapy, either docetaxel or pemetrexed. And as you can see, there was an improvement in progression-free survival in the patients who received Crizotinib. There was a trend to improvement in PFS with pemetrexed over docetaxel. And other retrospective series have also indicated that perhaps pemetrexed does have some particular activity amongst the rest of our cytotoxics for this patient population. In the first-line setting, though, as well, there was an improvement of PFS over chemotherapy. Not surprisingly, the overall survival difference wasn't noted, given the potential of these patients to receive subsequent lines of ALK inhibitors. Also, the patient quality of life reporting outcomes showed an improvement in symptoms with Crizotinib, including cough, dyspnea, pain, and many of the symptoms that we often see in our disease. So this is a overview of the data from first and second line trials of Crizotinib. So the Profile 1001 was the expansion of the phase 1 study, and then there were 2 second line trials, and then 1014 was a first line study. So the response rate consistently ranged in the 60% range for most of the second-line studies, slightly higher in the first-line study at 74%. And the median PFS also seems consistent, ranging from 7.7 to 9.7 months. Again, slightly higher PFS in the first-line setting, but still under a year. And the survival probability of this patient population was still quite high at 12 months, 84%. Leading to the need for second-generation agents to overcome this resistant population. Which leads us to Ceritinib. So Ceritinib was developed as a potent and selective oral ALK inhibitor in cell-based and enzymatic studies. It was about 20-fold more potent than Crizotinib. It also had some activity against IGF-1R and did not have the activity against c-Met, which we know that Crizotinib does have. In tumor models, the tumor xenografts were dosed with Ceritinib at varying doses, including Crizotinib, and as you can see, especially at the higher doses, there was a sustained suppression of the tumor in these models. So the ASCEND study was a phase 1 study which initially had a dose escalation followed by an expansion in patients who had alterations involving ALK. Other tumor types were allowed, but the vast majority of patients had ALK-positive non-small cell lung cancer. In total, 246 patients were enrolled in the expansion cohort. 163 of them had received prior ALK inhibitor, most notably Crizotinib, and 83 were ALK inhibitor naive. So the patient characteristics, again, this was on average a younger patient population, about 24 to 80 in age. And you can see here the breakdown of men versus female. The performance status overall, there was a good performance status patient. However, there were PS2 and even one PS3 patient who was enrolled on this study. The majority were never smokers, but still about a third of the patient were former or current smokers. I think illustrating the importance of really looking at this alteration in all of our patients and not selecting for smoking status. And again, they all had adenocarcinoma. It's also interesting to note that this was a more heavily treated population, and about half of the patients who had received prior ALK inhibitor had 3 or more prior lines of therapy. So the data illustrated that the response rate, especially in the prior treated group, was about 53%, 65% in the naive group, and about 57% in the total population. And at the time, I think this was one of the first examples we have of an agent developed in the resistant setting that actually had similar response rates to the first generation agent, leading to a lot of interest in this agent at the time. There were about 20% of patients who had stable disease. And you can see from the waterfall plot that the majority of patients who had treated, both who were ALK inhibitor naive and previously treated, had benefit to this agent. So as the PFS data has become more mature, it is clear that patients who were ALK inhibitor naive had an improvement or a greater PFS compared to the total population and those that were previously treated. At the time this slide was made, this was not quantifiable, but now it's known that the PFS in this group is about 18 months compared to 9.6 and 7.4 months. Actually, what did I? I'm sorry, duration of response, but again, this illustrates the PFS of about 18 months. So the other important factor with especially the second-generation agents is the ability to treat CNS metastases. And patients who have ALK-positive lung cancer have a propensity to have CNS metastases, and many of them require treatment with radiation and sometimes even surgery. But it's also important to address this with our systemic agents. So of the patients on this study, about 124 had brain metastases at baseline. Again, 98 had been treated previously with an ALK inhibitor, 26 were ALK inhibitor naive. And if you look at the RECIST measurable brain metastases, obviously this was smaller in each group, 10 and 4. This illustrates just radiographs of some of the activity that was noted in this population. As you can see here, this lesion did decrease, and this patient remained stable at the full dose after 17 months of treatment. And in looking at the intracranial response rates, amongst the tumors that were measurable by RECIST, 4 in the prior treated group and 2 in the naive group did have a documented response by RECIST criteria. And in general, amongst all of the patients, the response rate in the brain was about 56%, but much of that was due to investigator assessments, and it was difficult in that phase 1 study to really have a good grasp on the prior treatments amongst those patients as far as radiation. So it's also, I think, now known that Ceritinib is associated with toxicity. With Crizotinib, many of us became used to managing maybe some transaminitis and grade 1 ocular disturbances. Perhaps an occasional patient had bradycardia or peripheral edema. For Crizotinib, the toxicity profile really was more associated with GI toxicity. About 59% of patients on the ASCEND-1 study required at least one dose reduction, and 9.4% of patients discontinued treatment due to adverse events. A small percentage of patients, about 4%, also developed pneumonitis, but this is also, I think, a class effect to these agents in general. And so this shows an overview of Ceritinib activity. Again, now we have phase 1 and 2 studies in the first, second, and the first and second line settings. So the ASCEND-1 was the phase 1 study, which I just discussed. We also had the ASCEND-2, which was a second line study, and ASCEND-3, which did allow patients who were ALK inhibitor naive to be treated. As you can see, the response rate in this population is also slightly increased. And again, the median PFS in that series was 11.1 months, but amongst the treatment naive group, which I think it's not projecting here, but this is treatment naive and prior ALK inhibitor treated. Amongst the treatment naive group, as I mentioned before, in ASCEND-1, it was the PFS was 18.4 months. So again, just to review the toxicities that are noted with Ceritinib, including diarrhea, nausea, abdominal pain, fatigue, and transaminitis. Usually when I treat patients with this agent, I prophylax and discuss toxicity management as I'm prescribing it, and have sometimes ongoing use of antidiarrheal medications or antiemetics. Certainly dose reductions can be used if necessary. And one important factor of the transaminitis, this can also be related to concomitant medications, and so certainly trying to evaluate and minimize potential other agents that could contribute to this would be important as well. So Brigatinib was also studied in a phase 1/2 study, and this agent targets EGFR as well. So as you can see, the expansion cohorts included not just ALK-positive patients, but others as well. So I'll focus on the data from the ALK subset today. This, again, illustrates the demographics, and of the 71 patients who had ALK-positive disease, most of them were PS 0 or 1, and most had had 1 or 2 prior regimens of therapy. I think this is one of Corey's patients, and this again illustrates the activity of this drug in this patient population. So as you can see from the waterfall plot, again, many patients had a response. The objective response rate was 72%, and it was 100% in the 6 patients who were Crizotinib naive. In the patients who had previously been treated with Crizotinib, it was about 69%. And again, there was durability with regards to the time on treatment. And at the time that this study was reported, about 31 patients had been on treatment for at least 6 months, and 84% were continuing on study. And again, this illustrates the activity in the CNS with this agent, which also had CNS penetration. And as you can see, about 69%, although it was a small number, 9 out of 13 had a response in the CNS. So one of the symptoms which I think impacted the development of this agent was, and it is particular to this drug, was the sudden onset of pulmonary symptoms, notably dyspnea, hypoxia, and new infiltrates in a very short period of time after starting treatment. And some work had to be done to evaluate the best dosing strategy to minimize this. It seems to be less at the lower dose, and I think development has really been more ongoing at a lower 90 milligram dose. So Alectinib also resulted in considerable interest. It was initially presented in 2013 based on a phase 1/2 study that was conducted in Japan. As you can see in the xenograft data as well as the cell-based assays, this was also a very potent inhibitor towards ALK and also showed a prolonged tumor regression in the xenografts. So in the initial phase 2 portion of the Asian study, and this was a group of patients who were treatment naive, and ALK was either tested with FISH or immunohistochemistry, the response rate was really a dramatic 93%, and really a majority of the patients had a clear tumor shrinkage. And again, there is notable CNS activity. The dot represents patients who were ongoing at the time this was reported, and you can see many of the patients who had CNS disease were able to receive treatment for some time. So more evaluation that Dr. Gadgil actually reported was conducted with this agent in the US, and a separate phase 1/2 study was done here. This illustrates the different doses and the response seen in that series. The response rate in that population, which was a patient population who had previously received Crizotinib, was 55%, and the CNS response rate was 42%. And subsequently, a large global study has been conducted, which was an open-label, single-arm phase 2 study of Alectinib. And this was for patients who did not respond or progressed on prior Crizotinib therapy. They were treated at 600 milligrams twice a day. And the endpoints included response rate as well as evaluation of response in the brain. As you can see, they all had to be ALK positive. Prior platinum therapy was allowed. Performance status was allowed up to PS2, and prior ALK inhibitor was allowed. So amongst the entire population, the response rate was about 50%. In the patients who were chemo-naive, it was 69%. And the trial did meet its primary endpoint of response rate at the time of the data cutoff. And again, this is illustrated with this waterfall plot. So the CNS activity was also noted in patients who had measurable CNS metastases. There was a 20% complete response rate, and in all patients with CNS metastases, it was 27% complete response rate. So clearly there was CNS penetration, and again, partial responses were noted as well. So the adverse event profile of Alectinib overall has been fairly favorable. What has been commented on is constipation, fatigue, peripheral edema, myalgias, So much of this is grade 1 or 2, but sometimes does require management. The number of grade 3 and 4 toxicities was minimal. So currently there is an ongoing phase 3 trial of Alectinib versus Crizotinib in the first-line setting. And I think everyone really is awaiting this data to see if it would impact our first-line treatment of this patient population. So ASP3026 is another potent ALK inhibitor, which is somewhat earlier in development. Activity has been noted in EML4 ALK tumor xenografts. The DLTs that were noted included grade 2 nausea and vomiting, transaminitis, and we really are awaiting data on efficacy of this agent. So this illustrates the current data we have, at least with the more mature agents, Crizotinib. I still think of it as LDK, but Ceritinib, Brigatinib, and Alectinib, again, showing similar response rates amongst the treatment naive as well as prior treatment patients, and illustrating also the, I think, suggestion of higher progression-free survival if the agents are used initially. So moving on quickly to some of the agents that are now in development, a phase 2 study of PF06463922 has been reported. This is also a brain-penetrant selective ALK ROS-1 inhibitor. The toxicity profile in the phase 1 study is also different. About 60% of patients had hyperlipidemia, also peripheral neuropathy was noted, and mild CNS effects. Of the patients in this smaller series, 75% had previously received an ALK inhibitor and 43% had 2 prior ALK inhibitors. The initial confirmed response rate was 30% with a 12% unconfirmed response rate, but obviously this was a small number of patients who were valuable at the time that this data was presented. And currently, this study is now in a phase 2, this agent is in a phase 2 expansion cohort. X396 is another agent that's been reported in phase 1 and it's currently being evaluated in phase 2 trials. In the initial experience, 41 patients were treated, 18 had prior Crizotinib. The toxicities seen with this agent included fluid overload and rash, and there were also vomiting and fatigue was noted. Of the 17 evaluable patients, the response rate was about 59%. So again, I think we have to see more mature response data with these 2 agents. So in looking at the toxicities overall, I think, and I selected, I think, the more common nausea, diarrhea, edema, transaminitis, and pneumonitis. With regards to grade 1 or 2 toxicities, this was noted with Crizotinib and Ceritinib, also with Brigatinib overall, but not as much with the Alectinib. With regards to edema, there was slightly more with Crizotinib and Alectinib, not as much with the Ceritinib and the Brigatinib. Again, transaminitis was noted across most of these agents, perhaps slightly more with Ceritinib. And pneumonitis, again, is a class effect, which is rare, but I think can really occur with any of these agents, although it was reported more in Crizotinib and Ceritinib. So now that we have more agents to consider for our patients, it's clear that resistance continues to develop not only with the first, but also with the second generation agents. This data set really evaluated patients who had progressed on Crizotinib. And as you can see, there are now known secondary acquired resistance mutations, including L1196, which is a gatekeeper mutation, G1202, which now has some more emerging data, and there are others listed here as well. We still have a lot to learn with regards to activity of these agents in the resistant setting. When Ceritinib was evaluated in the phase 1 study, a small number of patients did have mutation analysis. As you can see, many of them were wild type for secondary acquired mutations, but there was activity noted in patients who had 1196 and some of the other ones characterized. And as we can see there's also emerging data with 1202. Perhaps this is a required mutation that does have activity with the third generation PF0646 agent. And I think this will be more important when we try to think of how to sequence these agents in the future. So briefly, I just want to discuss ROS-1. Again, this is a very small slice of the pie. In a series of 50 patients who were treated with Crizotinib, the response rate was 72%, with a median duration of response of about a year and a half. So certainly there was activity of Crizotinib for this population. What we don't really have as much data on are how to salvage these patients when they become resistant to Crizotinib. Many of the ALK inhibitors do have ROS-1 activity at varying degrees, but there really is a paucity of data in this setting. And I should note that the PF046392 agent does have a ROS-1 cohort in its phase 2 study. And finally, RET translocations is also, I think, an emerging interest in non-small cell lung cancer. And again, it's very rare. This just illustrates, again, how FISH can be used to assay it. And in a series of patients that Alexander Drillon had studied with Crizotinib, which again was a small series, you can see that there were responses, about response rate of 44% and 56 having stabilization of their disease. So certainly I think there's more to come for this population.